So my topic is to give you some evidence, at least available evidence, whether the reconstitution of the immune system and the improved reconstitution via plasma exchange is related to the outcome of natalizumab associated PML. And you know, and Dr. Berger gave a nice talk in the morning, that previously when we thought about PML, we thought about compromised immune systems there, and HIV is still the number one until some 5 or 8 years ago, as you see it. Natalizumab was introduced, originally discovered 1992 by Ted Yednock and colleagues, fast translational therapy, blocking adhesion molecules, VLA4 receptors on the leukocytes, and probably acting at several levels, most importantly, stopping lymphocyte migration to the brain, and this is rather selective at the brain and the gut, these receptor mechanism, so blocking immunosurveillance, but there's also some role in leukocyte priming and modulation of T-cell apoptosis. So I will address 3 major messages. The one is I will try to summarize the evidence that natalizumab really causes immune suppression, and can you make this reversible via PLEX? Can you enhance immune reconstitution? To give you further insights, I will also compare the natural outcome when we did not perform PLEX with those who received plasma exchange. And finally, I will address immunoabsorption, although I must admit this is more European taste. I'm aware that it's not that available in the US because we can more specifically remove antibodies, especially IgG4 antibodies such as natalizumab. So you have seen this slide today in many variations. All of us are convinced that there is a treatment duration-related incidence. And this speaks that the immune system gets some suffering from exposure to natalizumab, although the mechanism is not well understood. And in view of the high standard deviations here, it looks like a plateau, but this has already been discussed before. We have heard about efgartigimod, Raptiva, which also had a very high incidence and meanwhile has left the market because in contrast to Tysabri, a very strong medication which we need for MS, this is a molecule where we have alternatives. So but again, efgartigimod, anti-LFA, then anti-alpha-4 beta-1, natalizumab, it's adhesion molecules. And why are they so specifically associated with brain infections during the viral infections and JC viruses? We don't see this in MS. We don't see PML associated with MS even in the 1990s when we applied very harsh treatments, cytostatic treatment with mitoxantrone, cyclophosphamide, leading to alopecia, leading to bone marrow suppression. We never observed this. So obviously, it's not only the activity of the immune system, but it's also the reduction of CNS surveillance. And what can the clinical observations tell us about the underlying biology, since all of the speakers today have already mentioned the mechanism is incompletely understood. The best way certainly is to reconstitute and reverse this immune suppression. And the question is, can this be achieved by any type of plasmapheresis, either PLEX or later on immune absorption? At least the synchronized iris, this immune reconstitution tackled afterwards by Dr. Berger in a second talk, says yes. We more or less like a law, we have after performing PLEX in natalizumab-associated PML, we have iris within 3 to 5 weeks post-PLEX, and it takes somewhat longer, up to 3 months without PLEX. So we have a synchronization of the reconstitution of the immune system. Then, of course, you have to combat iris. Again, this is part of the next talk. And we can do some bioenergetic assays. This is called the SILEX. I will briefly give you some data on this. This is from a SILEX company at Columbia, and the test assay, FDA license, is called Immunov test assay. It's a bioenergetic assay with a polyclonal stimulation of CD4 immune cells. We have published this just recently in PLOS ONE, and I take some of the graphs out here. Normally, if you do it in normal healthy controls, but also in MS patients, you have about 500 units of ATP in a chemoluminescence assay. Lymphocytes are stimulated polyclonally overnight. You see the HIV patients, and those who are lower are AIDS infected, already AIDS transitional HIV patients. The lower third percentile is here around 230 ATP units. So if you now look especially at our German cases, you've already heard, unfortunately, quite a lot of cases in Germany. The first two patients, we had opportunities to get blood before they had plasma exchange, here and here, and they were at the lower level of the lower third percentile and stabilized afterwards. And during the further disease course with intensive care unit, etc., they came down again, but always higher. When we got blood only here at this later stage, then they were already in the normal range. And we, of course, also sampled blood from other PML patients, Rituxan, very low levels, natalizumab from Heinz Wendel at Würzburg at that time, spontaneous PML. So I do not claim that this is an assay to forecast whether someone will develop PML, but at least when people have PML, they are very low, and at least via Plex, you can support the immune system. Again, I'm aware we talk about CD4 cells, the assay is standardized for CD4, and Igor Koralik and other colleagues have shown nicely that CD8, of course, is much more important in the viral infection. But we have some reversal. So what happens naturally if we don't perform this, if we take the natural way, waiting for the immune system to get rid of natalizumab, and if you compare it with the plasma exchange? So in the left column, you see the forced approach via plasmapheresis procedures, and here you see the natural way. If you infuse 300 mg of natalizumab every 4 weeks, you see plasma levels of about 100 micrograms per ml. This antibody has a half-life of about 10 days. So 4 weeks later, you're around 10 micrograms per ml. And within 2 months after the last infusion, 2 to 3 months, you have completely eliminated it. You can enforce this elimination via plasma exchange. In Europe, we have also the option of immunoabsorption, which entered our neurological understanding in Europe mostly from myasthenia via Toika and Shibuya here in Trusted. If you look at the survival rate, you can see that, as you had before, we only have a 20% fatal outcome. There seems to be a major difference between the States and between Europe. So 80% survival, very much different from HIV. If you look at the spontaneous way of elimination, please remember the pivotal study patients. We've heard it. The third one is severely disabled somewhere in Texas. We have some spontaneous and mild causes. There's a Dutch case associated with some very peculiar circumstances that no Plex was made. Also, Dr. Bertolotto seems to have a very mild case without Plex, with a mild case of iris. And you have already seen that. I acknowledge it's from Sandro Richman from Biogen, and just want to make the point that if you look at the outcome in terms of Karnofsky's index, and remember, we have no exact data before at the MS, but due to the indication, the MS patients should have an EDSS of 4 and lower if they go to Tysabri normally. So this means, translating to the Karnofsky, 90 to 100 points. And about 13% come out in the same range, 50% with moderate disability, and most of these are also of the 40s, so close to moderate disability. So overall, in the survivors, the outcome is rather well. Of course, we have some excellent outcomes. This was a case we published from Bochum. We have now 10 patients at my department from the German, PML, natalizumab reservoir, I would call it. So I have treated 10 patients so far. And she was lucky, she had a frontal lesion. It's, of course, a site of the viral infection. We plexed her, immunoabsorption. She developed iris here, as you can see, with the gadolinium. And then she had some spread, and later on she had some gliosis. And she is completely out at the same EDSS as before. So this was a lucky site, and this, of course, cannot be directed or guided. So when you now compare, you've seen this in Joe Berger's as well, when you compare the outcome of the patients who developed iris with either Plex or immunoabsorption or combination, you see it's 67%, and then you see it with no Plex and no immunoabsorption, but you have to be aware that also if you look at the survival here of these, no Plex or no immunoabsorption, during the pivotal studies, you have 2 or 3 patients, 2 patients who died and 1 who got out severely disabled. But there are some mild patients without Plex, I must admit. So If you look at the Rituxan, which has been also discussed before, and I cited this paper from Carson and colleagues, of course, the situation is much different. It's much less frequent, the anti-CD20, but the outcome is usually unfavorable. And this again suggests we cannot remove the biological activity of Rituxan. If you come more than 6 weeks later, the antibody has gone, but the B cells and the precursor cells are destroyed, so you don't have a chance to get out and reconstitute the immune system. And this again suggests that an intact peripheral immune system is important, and we need the cells go back into the brain and do the work, especially because we heard that so far no good therapy is available. One point which I have not heard today, but I'm sure the real experts in PML know this. This is one of my cases. She was diagnosed late July. You see her here. She had apraxia. She had a left-sided hemiparesis with foot drop. And then we plexed her. Immunoabsorption, you see a very mild iris, and you see a diffuse gliotic scarring here. So at least what I see from the German field, and many people contacted us. Heinz Wendel has built up a network with a German Ministry of Research. There, I would say 1 out of 3 or 1 out of 4 patients who have MS, who don't have HIV, but who have problems to eliminate the virus and the virus spread, even after removing natalizumab. So I would say, at least in my limited experience, and I don't do further biological examinations in there seems to be a subgroup of MS patients who has difficulties to get rid of the virus. Although natalizumab has been removed and although iris has been treated accordingly. So I would just like to make this point, at least to my experience from the German field. And in the last set of slides, I would like now to tell you a little bit more about this immunoabsorption and compare it with plasma exchange. Both are methods of plasmapheresis. With a plasma exchange, also abbreviated as PLEX, you have semi-permeable membranes with a molecular cutoff. You remove inflammatory cytokines, proteins. You have to reinfuse albumin, maybe some allergy and so. So this is a standard also for Guillain-Barré, for example. When you want to remove antibodies, you can take advantage of their physicochemical properties. They bind very well to some immune adsorbers. One of them are, for example, pegylated tryptophan, which you get in some customized columns. And this was introduced into myasthenia. We were very clear about the target myasthenia, acetylcholine antibodies. And this is certainly superior for myasthenic crisis, as we showed during work at Würzburg. And we thought that if you want to get rid of an IgG4 very fast, very synchronized, then maybe this is even faster. So now if you look at the data which are available, very systematic study by my colleague and friend Bob Fox from Cleveland. This was sponsored by Biogen, and they did it at 2 centers. They did a series of PLEX, 5 PLEX procedures, standard plasmapheresis procedures. You can see here the alpha-4 integrin binding. You see here the level of natalizumab measured in the plasma. And I should note there that the cutoff for natalizumab to get rid of the VLA4 receptors, to desaturate the VLA4 receptors, is between 1 and 2 micrograms per mil. And this is a little bit a high scale, but you see that you need at least the 5th one to get in this lower range. With the second and third one, there is some redistribution of antibody from the tissue compartment, so it's very hard. You need at least 4 or 5. So do we have any systematic data on immunoadsorption? Unfortunately not, but we can compare the both case reports from the Swedish patient and from our German first patient. And when Thomas Olson and colleagues sent their samples to Biogen for measuring it, they started at 14.4 micrograms per ml before plasma exchange, and after the third treatment, they were 5 micrograms, remember, quite above this lower range of 1 to 2. We did immunoabsorption. We started and we sent blinded coded samples to Biogen and then got back the results which we uncoded. And we started at 10.8 micrograms per ml. And after the third immunoabsorption, you see that we were below the detection level. So at least you can accomplish it further, and this is further strengthened by a paper by my colleague Dr. Kleidhö, He published in Multiple Sclerosis. The slide was taken out because of space limit, but you see it here. They also did in a natalizumab-associated PML immunoabsorption, and you see here after 4 immunoabsorption cycles, Susan Girls and Biogen provided the data. You are here at a very low level between 1, so you have desaturated your leukocytes again, and you get a fully active immune system. So if you come with a final question, should we plex or not plex? I must admit, honestly, I have no claims, no stakes on this. There are no controlled studies really available. I have tried to bring you some indirect evidence for plasma exchange or plasma exchange procedures. You get it synchronized, you get it more predictable. Then, of course, you should not do it when you cannot handle iris. Maybe provide intensive care unit care to the patients, cost a little bit more money. We are aware of economical situations, but I think Dr. Berger will further allude to this. And at least from my standpoint, if you really want it fast, then we do it faster with IgG4 removal if you use immunoadsorption columns. Of course, you can use protein A, which is even more expensive. I would like to thank my consultant colleagues who helped me with this patient, especially Kerstin Hellwick, also here, Alexander Schröder, and we always had stimulating discussions with Susan and Sandra. Thank you.